Okay, our next speaker, it will be done virtually because he's unable to travel here to Singapore. It's my pleasure to introduce Associate Professor Jeremy Teoh, who is the Assistant Dean External Affairs, as well as Associate Professor at the Faculty of Medicine in the Chinese University of Hong Kong. He's a urologist. His main interest is in managing bladder as well as prostate cancer. He is currently one of the key opinion leaders, especially in bladder cancer, in en-bloc resection of the bladder tumor. He has done a lot of work in this, including leading a global consensus statement on this subject. He's also a fast rising star in the Chinese University of Hong Kong with urology. He's been voted one of the 10 Outstanding Young Persons Award in Hong Kong, as well as multiple other awards. He's editorial member for a number of prestigious prominent journals, and is also the founder of the largest urology social media network called Urosomi. So he has many multiple interests, and it's my pleasure to welcome him to give this talk on en bloc transurethral resection of bladder tumor.
Hi, my name is Jeremy Teoh from the Chinese University of Hong Kong. First of all, I'd like to thank the organizing committee for the kind invitation. And today I'm going to talk about en bloc transurethral resection of bladder tumor. So TRBT, conventional way of doing the procedure, is to resect the tumor in a piecemeal manner. It was introduced back in 1926 as a minimally invasive procedure, and up to now, it is still the current gold standard for the diagnosis and initial treatment of bladder cancer. However, what we observe is that the cancer control of non-muscle invasive bladder cancer is still quite unsatisfactory. On average, 1-year recurrence rate is probably about 30–40%, and 5-year recurrence rate is up to 78%. Therefore, with so many adjunct treatments that we can consider, including intravesical chemotherapy, second surgery, as well as BCG treatment. And even after a complete resection, we still need very stringent surveillance cystoscopy protocol in order to detect any early disease recurrence. So what are the problems with the standard TRBT procedure? Firstly, we resect the tumor in a top-down manner. Sometimes after resection, there can be a lot of cauterization artifact. And it's very difficult to ascertain complete tumor resection. And whether a complete resection has been achieved is totally dependent on the surgeon's experience. And sometimes there can be residual disease at the resection bed. Secondly, during the resection procedure, we actively fragment the tumors. So the whole bladder will be filled with tumor fragments. And theoretically, these floating tumor cells may also implant to the bladder mucosa and lead to early disease recurrence. Therefore, en bloc resection has been proposed as an alternative surgical technique, aiming to avoid tumor fragmentation, minimize the chance of reimplantation of tumor cells, as well as ascertaining the complete tumor resection, not only by your bare eyes, but also by a formal histologic assessment of the resection margins. So for a en bloc resection procedure, this is just an illustration using a one-sided tumor over the left lateral wall. Usually we use the bipolar resectoscope. We cauterize, make a cauterization marking circumferentially. This will really aid your incision afterwards. And usually we would distend the bladder slightly in order to facilitate the subsequent incision. We usually mark the margin about 5 mm from the visceral tumor, and it's been shown to have a very high clear resection margin rate following this 5 mm rule. Afterwards, we incise using an intermittent burst technique. Because the bladder is slightly distended, once we step on the pedal, the mucosa and the submucosa tends to tear apart. And remember, mucosa and submucosa, they're very soft muscle. The crossing fibers, they're more fixed below. So when we push the mucosa and submucosa, we can easily recognize the margin between the submucosa as well as the muscle. Rotate the lobe a little bit, so the yellow part and slip part is kind of pushing the tumor now, and therefore it creates some tension for the incision as well as avoiding inadvertent damage to the tumor specimen. In that way, you can excise the tumor nicely while preserving the quality of the tumor specimen. After incising the margin circumferentially, then usually the tumor will shrink into the middle, and you will see very nice crossing fibers surrounding at the base of the tumor, and then you know where the depth of incision should be at. Afterwards, you can either excise the tumor in an antegrade or retrograde manner. It doesn't matter. So you push the tumor, you recognize where the margin is, and then you proceed with the excision. And afterwards, you'll be able to see a very nice specimen like this. So usually we'll pin the margin against a foam board, so our pathologist will be able to understand the orientation, and then they will prepare the blocks accordingly. And therefore, they will be able to assess the tumor, the depth of invasion, as well as both the circumferential and deep resection margin. A few years back then, I've done a systematic review and meta-analysis with the EAU group on the effectiveness of en-bloc resection compared to piecemeal resection. There are quite a handful of RCTs looking into this comparison. However, most were only single-center studies, and the sample size is still quite limited. But what we found is that in en-bloc resection, of course, it would take slightly longer in terms of operative time, on average about 9 minutes longer. But then it has a potential benefit in terms of reduction in irrigation time, so hemostasis seems to be better. And also, a bladder perforation rate is actually lower in en-bloc resection group, and it makes sense because resection is very precise, intermittent burst manner, and therefore, if there's any optic reflex, we'll be able to recognize early and avoid unnecessary perforation. In terms of recurrence rate, however, all the studies, most studies do not look into this oncological outcome, and the sample size is limited. So far, we still didn't recognize any benefit in terms of recurrence rate. But having said that, there are a lot of other RCTs that are ongoing, including the first one here that is being conducted in Hong Kong. So it is a randomized study that has recruited 350 patients, randomized to en-bloc versus conventional TURBT. We've already completed patient recruitment. We've already completed the 1-year follow-up, and we are about to write up the results soon. Hopefully, we provide some high-quality evidence in terms of recurrence rate. The other question is really whether this approach is feasible for bigger tumors in order to improve its generalizability. So a few years back then, another friend of mine gave me a challenge. So he saw a tumor like this, and he said, "It's a big tumor. Why don't we try en-bloc resection?" I said, "Okay, let's try." So during the procedure, we spent probably 1 hour to complete the removal of tumor in one piece. But as expected, we had difficulty in removing the tumor. We spent a long time, but still failed to remove one piece. At the end of the day, we need to remove the tumor in multiple pieces. So strictly speaking, not really en-bloc removal. But to make it worse, I feel that the tumor base is unhealthy locate. I feel that it's actually a muscle-invasive disease. So at the end of the procedure, I feel very bad. What am I doing? I failed to remove the tumor in one piece. The base looks unhealthy. It's probably a muscle-invasive disease. So a surgery like this may not be helpful. So what am I doing here? But I was surprised 2 weeks later when the pathology came back. It came back to be T1 grade 2 disease. And second surgery was negative. So when I look back, if I thought it is muscle-invasive disease, if I did conventional resection, I probably would stop early on. I probably won't have such a radical resection as in the case of en-bloc resection. That's really the point when I realized endoscopic assessment of the depth of tumor invasion is really, really inaccurate. And therefore, we should treat every case as a possible non-muscle invasive disease, even in big tumors like this. And come back to be non-muscle invasive in terms of pathology, then you can really help the patient because good endoscopic resection is a key to ensure a cure in those cases. 2 weeks later, I have a similar case. This case is better. During the surgery, I feel that the tumor base is actually very healthy, and histology came back to TA grade 2, and psychosurgery was negative. And this is the point when I realized that en-bloc resection, the key is really to ensure a good, complete local resection. And whether you remove in one piece, multiple pieces, it doesn't really matter in terms of big tumors. And therefore, for large bladder tumors, first of all, it's more likely to muscle-invasive disease, so proper staging is important. But in case the patient is lucky enough to have a non-muscle invasive bladder cancer, ensuring complete local resection is most important. And therefore, nowadays, I try to adopt this concept of modified en-bloc resection. That is, we try to resect the tumor as en bloc as reasonably achievable. So in the best case scenario, remove the tumor in one place on block resection, but then there are also some modifications that we adopt. So firstly, we can resect the exophytic part of the tumor in peaceful manner, make it more flat, and then proceed with ocular resection of the tumor base. This is an approach that we can adopt. Sometimes when a tumor area is really too wide, then we might need to even divide the tumor in multiple pieces, but still you can do it in en bloc manner first. In the worst scenario, when the tumor is really, really big, you feel that it's almost impossible to do modified en bloc resection at all, then we have to refer to conventional TRBT, isn't it? But what if we still follow the principle, going from circumferential normal area, from normal to abnormal, from known to unknown? We take reference from the edge, knowing the depth of the muscle layer, and resect as radical as possible. I put a question mark here whether this can be considered modified en bloc resection, but this is what I've been doing even for big tumors. And I will show you some videos and also some photos and let you be the jury. So big tumors like this, of course, is impossible to remove the tumor in one piece. But in this case, what I did is basically resecting the tumor, the exophytic part of tumor, and then make it more flat and smaller. And then I proceed with ocular resection. This case, because it's as a lateral wall, there's optic reflex. So once I reach the junction between the submucosa and the muscle, then I use the resection lobe to actually push the tumor and tear the tumor away from the muscle layer. It's almost like an enucleation-like of technique. This way you can avoid the optic reflex. And then you can see the blood vessels are very visible. You can perform hemostasis precisely. In this case, with the second surgery, it's actually negative. Finally, it's a T1 non-muscle invasive bladder cancer and still disease-free. This case is the worst case scenario. When the tumor is really, really big, I feel that it's impossible to perform the en bloc resection, but I still follow the principle. I mark the margin circumferentially, and then I still try to incise the lateral wall. In this case, it's really, really bad because I can't see the right UO. I can't even see the left UO. But as you can see, now I am incising on the proximal margin, the margin that is nearest to me. You have to perform some hemostasis because there tend to be some blood vessels at the mucosa and submucosal layer. But then you go laterally, trying to mark the normal margin for yourself, and you know as you tackle the deeper part of the tumor, you know what is the depth of the resection that you should aim for. And it's always good to go from normal to abnormal because normal layer, it's always a good reference to take note of. Really incising the margin circumferentially helps you know how far you need to go during the resection, and I always do that as soon as it is possible. You can see that because you mark the margin initially, so you don't have to go back and forth, you know which direction you should go for. And usually it will be quite easy to complete the margin incision. And then the other thing is you can see optic reflex here. So if you see an optic reflex like that, then first of all, you can try to lift the mucosa, try to get it away from the reflex area. Secondly, you can ask the assistant to help reduce the dosage, the voltage a little bit. You can also try to make the bladder a little collapse. That's also fine. So after the incise on the submucosa and mucosa, I'm doing some hemostasis. But what I'm doing next is to again try to get below the tumor, but taking reference of the margin, which I'm going to show you later. So here, I'm trying to incise down to it until I reach the muscle layer. You can see I'm rotating the lobe so that I'm trying to get below the tumor while avoiding injury to the tumor specimen. And because I know where the depth of the muscle layer is from laterally, so it's actually much safer to resect below the tumor. You try to get as radical as you can, but at the same time, you avoid being too radical and risk the potential danger of bladder perforation. In this way, you can always take reference from the surrounding margin. And again, you can go as radical as you can. At the same time, you try to recognize whether you can see any muscle layer below. Occasionally, you might push a little bit and then try to make yourself a better vision. Now you can see. So this is likely to be the margin between the submucosa as well as the muscle layer. So here, yeah, so this is a submucosa, but below you start to see those crossing fiber. So you start to recognize the margin of the submucosa, mucosa, and muscle layer. So there it is. So that is margin. So you try to incise of the margin. Always take reference from laterally, so you know that you don't have that you shouldn't go too deep, and then you proceed with resection. By doing this way, basically, you always take reference from the margin laterally, and therefore you can have a relatively radical resection even in difficult cases like this. Very luckily in this case, when I incise on the left side margin, initially I can't see the UO, the ureteric orifice, but because during this procedure you get really deep to the muscle layer, at a certain point you will cut the ureteric orifice. In this case, very luckily, because we use bipolar intermittent burst technique, the UO actually popped out after the resection. And so at least one side kidney is not obstructed. And hopefully we can preserve some kidney function before we proceed with the next step of treatment. In fact, in my center, we're doing a phase 2 trial on this rather exploratory concept. We included patients with big bladder tumors of at least 3 centimeters. 30 patients are to be recruited. And we look into a composite outcome. And that is for patients with non-muscle invasive disease, we investigate whether such approach can show a complete resection. And for muscle invasive disease, we look into whether we can have a proper staging and a first surgery, because understaging with disease is still a problem in our field. So basically, all patients will be recruited, who are recruited will have pre-op MRI scan. We do modified umbilical resection. If it's a non-muscle invasive disease, upon resection, then we offer a second surgery for the pathology, making sure that it is cleared and it is really non-muscle invasive disease in nature. For patients with muscle invasive disease, then we worked out for any metastasis. For those with localized disease, then we offer radical cystectomy, which again will have a second specimen in order to compare with the first specimen. And just to show you some MRI scan before and after surgery. This case, T1 high-grade tumor, big tumor. After surgery, the tumor is resected. You can still see some postoperative changes, but that's been proven to be T0 disease upon second surgery. This is another case, T1 high-grade over the anterior. After the resection, the second surgery came back to be T0. There are some cases which are really interesting. This case, although it looks rather small, but I realized that MRI scan sometimes can really underestimate the area of tumor, because endoscopically it's actually a wide area of tumor, rather infiltrative and flat type of tumor. And therefore, after the resection, you can see the postoperative change is actually a lot wider than how it looks like in a pre-op MRI scan. But this is likely to be an early T2 case. And when we do radical cystectomy, it's actually a T0 disease. So these are the scenarios where a good radical resection may actually help. We may even consider chemotherapy, radiotherapy, child-medical treatment if the patient doesn't want radical cystectomy. Another case, really big tumor. What we did is basically what I've been showing in the last video. So we make use of the circumferential margin. We try to resect the tumor base with reference to the normal layer circumferentially, and after resection, we are able to have a rather clean type of bladder wall. This view is a correct view because you can see the resection area, the base, actually there's some postoperative changes, but radical cystectomy again showed T0 disease, which is really, really good. So in certain cases, modified umbilical resection may actually render a cure. But in some cases, the tumor is really, really bad, and even umbilical resection will not be able to help. This tumor, preoperatively, we do the MRI scan over the left posterolateral wall, T2 disease upon umbilical resection, After the surgery, with the MRI scan, actually you can see that the mass is actually extend beyond the bladder wall, and actually radical cystectomy came back to be T3 disease. Another case, a big tumor over the right side posterior wall. After resection, looks really nice, right? But if you look carefully at the base, it looks a bit fishy. There seems to be some mass below. And after the radical cystectomy, actually came back to be a T3 high-grade disease. So in some cases, it does not help. And we rely a lot on radiology in patients where trauma-diet treatment is considered feasible, then maybe a more radical surgery followed by chemo-RT is the way to go. So in our preliminary results, we did 18 cases. 1 case was prostate cancer and was excluded. In 10 cases, it was non-muscle invasive disease, and the second surgery confirmed no residual disease in 90% of the cases. Remaining 7 cases of muscle invasive disease were able to stage it properly in the first surgery. 5 of them underwent radical cystectomy, and 2 of them was confirmed to be T0 disease. So 40% of T0 disease is actually quite good when you compare to historical series. So modified en-bloc resection achieved complete resection of non-muscle invasive disease or proper staging of muscle invasive disease in 94% of the cases. In summary, en-bloc resection aims to ensure a complete local resection and minimize the risk of tumor implantation, safe, feasible for smaller tumors less than 3 centimeters, at least equivalent, potentially superior to conventional TRBT, but oncological results from a large-scale RCT or the center trial is to be awaited. And en-bloc resection can be challenging, especially for big tumors or tumors located in areas like bladder tumors. But modified en-bloc resection can be considered in those difficult cases. I really think ensuring complete local resection is most important for non-muscle invasive disease, even for big tumors. And for muscle invasive disease, the goal is to have a proper staging and radical resection in case of trauma-diet treatment. And based on our preliminary results, I believe modified approach of en-bloc resection should be considered an acceptable compromise. If you're interested in this approach, please feel free to look into this consensus statement I've developed. Basically, it's listed out details of the procedure, preoperatively, perioperatively, postoperatively. If you're interested, feel free to have a look. Hopefully, it can be a reference of standard that you can take note of. And by this, I would like to end my presentation. Thank you very much for your attention.
Thank you very much, Jeremy, for the very wonderful talk. Hello, Jeremy. Can you hear us? Can you hear us? Is he on? Is he able to have audio?
Hello.
Hi.
Can you hear me? Hi.
Yes, wonderful talk. Thanks very much, Jeremy. I always enjoy your talks on TURBT. You show very nice videos and a lot of daring. Anybody in the audience would like to ask a question? If not, maybe I can ask you, you showed your modified en-bloc resection, which is a kind of changing paradigm and a very new concept. Is there difficulties with regards to bleeding? Because if it's potentially, let's say it's muscle invasive, we may be potentially cutting through tumor. Is there an issue of more bleeding compared to non-muscle invasive disease?
Well, I think for muscle invasive disease, definitely it's technically challenging. And sometimes it's can be quite scary. But then we always take reference from the surrounding area, the normal muscle layer, and we try to estimate the correct depth. I would say bleeding is not a major concern, generally speaking. We'll be able to control the bleeding quite well, but it's really whether you can get to the correct depth, which is difficult because for muscle invasive disease, understandably, the base can be quite unhealthy looking. So it really comes with experience, but as a surgeon, as I've mentioned, from known to unknown, we always take reference from the surrounding area. Usually it will be fine. Yeah,
thanks. So it sounds like for these potential cases, you are doing more MRIs, which is not, again not conventional in most bladder cancer management or TURBTs. So is that your routine now if you suspect a deeper tumor to decide on the depth of resection?
No, it's not a routine, at least not at my center. So the cases that I've shown you, they are all done under a clinical study, a research setting. So we have pre-op and also post-operative MRI scan. And I think most of the time you probably do not need it unless you are really thinking about those early tissue disease. You really want to know whether a radical en bloc resection can potentially eradicate the disease followed by chemo and RT, etc. I think these cases, MRI scan is most helpful. So, I mean, clinically, I don't do it routinely, but in selected cases, I think that can be able.
Okay, one more question for you, Jeremy. You know, up to a few years ago, there's been people, the groups advocating using like water jet hydrodissection, laser technology. I see that you favor the loop, the conventional loop to do this en bloc. What are the advantages of the loop versus these technologies, and what's happened to these technologies? We don't hear much about these anymore.
Well, there are a few reasons why I tend to use bipolar. So firstly, it's very easy to have the equipment. It's available everywhere. It's very sharp and precise because of the bipolar nature. During the incision, it's not just a sharp cut, but you can also make use of the loop. You can push the tumor. It's a combination between a blunt as well as a sharp dissection. And also, if you are dealing with tumors, say at the bladder dome, if you are using laser, then it's always an end-on type of laser firing, and it's really difficult to control the depth. Whereas in bipolar, if you resection of it's still kind of a perpendicular orientation. It seems to be safer in those dangerous locations. So generally, I use bipolar. For water jet, I think the idea really comes from the GI tract when they try to elevate the mucosa. But I still feel that in bladder cancer, at least the current concept is still resection down to the muscle layer. So if you artificially elevate it at that junction between the mucosa and the muscle layer, then in theory, you're raising up the whole thing without a muscle layer. So I'm still not particularly convinced with the whole principle. For muscle invasive disease, I haven't really tried using water jet. I can't comment on that, but I guess it might be difficult because everything will probably get stuck in between.
Great, thanks. Yeah, any other questions from anyone else? One last question, Jeremy. You know, having led the consensus, you know, and pushing a lot of headway into en bloc resection, what do you feel is the key barriers to, you know, it being done in most centers where we're still doing, you know, piecemeal resection, which is oncologically doesn't make sense. What is your thoughts and, you know, your feel about, you know, all the barriers that are inhibiting most urologists from doing proper en bloc resection?
Well, I think there are two things. Firstly, I think most people would agree that en bloc resection is good, but it's not superior to conventional resection in terms of oncological outcomes. At least we don't have that level 1 evidence yet. And so people feel that it's good, but there's no strong indication that we must do it. But having said that, there are a number of randomized trials that are ongoing, including one that has been done in Hong Kong. We have completed the recruitment. We randomized 350 patients. We have completed 1 year follow-up, and we are actually about to report the results. Our primary outcome is 1 year recurrence rate. And hopefully with more results, we'll be able to show whether it carries a genuine benefit in terms of cancer control. And if it does, then there will be a stronger reason to adopt this approach. And secondly, it's really about training and dissemination. I mean, when you begin doing a new procedure, you still have to go through a learning curve. And having a good training program, a close supervision by more experienced surgeons, I think is really the key to ensure a safe and wide dissemination. And that comes to, as you know, in OSTEC, we're doing a lot of training activities as well. So with more evidence as an approach, we'll probably try to push more in terms of training and dissemination of technique, at least in Asia.
Great. Thank you very much.
Thank you.
Thank you. I really enjoyed your talk, and it's been wonderful to interact, and thank you for spending the time with us. Thank you so much.
Thank you very much.